I work in the Schulich School of Engineering at the University of Calgary. I have a lab in the Faculty of Kinesiology where I have a joint appointment, and I have another lab in the Faculty of Medicine. So I spend a lot of time walking around on campus to different sites. So what I want to talk about today is, as a biomedical engineer, what I do is I work with, in an oversight, I work with bone and joint injuries. But what I want to specifically talk about today is my focus on osteoporosis and bone strength. So osteoporosis is a disease where you have low bone mass that can lead to a high risk of fracture. Obviously, it's very important to avoid fracture for your long-term mobility and health. So one of the problems, though, with the way that we look at fracture today is that we use tools, medical imaging tools, such as DEXA, which is a tool that measures the amount of bone mass that we have per unit area in the bone. With osteoporosis, it's very important to treat this disease. It's called the silent disease, yet we don't do a very good job of that. I would say of all the people who have osteoporotic fractures, less than half of them would actually be diagnosed as having osteoporosis. And that's if you're talking about women. If you're talking about men, less than a quarter of men who have had an osteoporotic fracture would actually be diagnosed with the disease. So we don't do a very good job of identifying who has osteoporosis. Part of the problem is the way that it's done clinically is we measure bone density. Bone density is more or less a measurement of how much material you have. And from an engineering perspective, it's more than how much material you have when you build a structure. It's how that structure is designed to optimally be strong. So you can, for example, have a house built of 1,000 bricks, but you can have a lot of different quality of houses built from that 1,000 bricks. So what I'm interested in is bringing in the other aspects that are important to bone strength, of which microarchitecture, so that is the organization of the bone, is an important aspect. And understanding how that is important in the development of bone and how that is affected during the disease and how that may lead or how that can be altered again with treatments. So I use high-resolution computed tomography, so a three-dimensional imaging tool that gives us very detailed images of bone structure. A lot of the research we've started with is in mouse and rat models, so we're understanding the relationship of bone development over time and how these interventions, pharmaceutical or otherwise, can impact the bone structure. We've recently been doing a lot of our work with humans because we have a new tool now that can measure three-dimensional bone microarchitecture, so the structure, in people at the wrist and ankles. So this is very new technology, and we're starting to learn now more in people how bone develops with age and how that's affected by disease, and again, how different kinds of pharmaceutical treatments or other kinds of treatments can intervene. So in the end, what we also do is we bring into these imaging technologies other engineering tools. For example, a method called the finite element method is widely used in engineering for the development and design of structures. Well, that same kind of tool can be applied here in the medical field, where we have these very detailed images of bone to estimate how strong your bone is, so specifically to a person. So a lot of this research, what I would love to be able to do in the future, and something I'm applying for in grants right now to do, is to bring this into the clinical world. So in Canada, we have over 2 million CT scans done for non-bone related reasons. These CT scans would typically be of the abdomen area, which are very important sites for bone-related issues, so the spine and the hip. So what we have an opportunity to do here is to take that data that's being collected for other reasons and use that to also screen for bone health issues. We've developed all the tools based on the animal research and now our human research, and why not take a chance and try to apply this in the clinical realm as well. So the bottom line, what we want to be able to do is we know that there are new drugs and new therapies that are on the horizon that are effective. If you're talking about drugs, they're very expensive drugs though. So what we need to be able to do in our aging population, where mobility is an important thing, we need to be able to identify well who the people are that should be receiving these drugs so that we can use our healthcare dollars wisely to focus it on the people who need the treatment and do a better job of identifying people who have a chance of osteoporotic fracture. So, thank you.